Is Levodopa helpful during rehabilitation after stroke? What percentage of U.S. children are insured under Medicaid or CHIP? Do manufacturers of medical AI devices give payments to healthcare providers and hospitals? This and much more on today's JAMA Editor Summary. Hello and welcome to our listeners around the world. Today is Friday, September 26th, 2025. I'm JAMA Deputy Editor Dr. Linda Brubaker, sitting in for Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. For this episode, I'm joined by JAMA Deputy Editor Dr. Preeti Malani. Hello, Preeti. Would you like to start us off with the Editorial trial?
Hi, Linda. I'd love to start us off. Editorial stands for Enhancement of Stroke Rehabilitation with Levodopa. It's a randomized clinical trial by Dr. Engelter and colleagues. Levodopa enhances dopaminergic signaling and may stimulate neuroplasticity. However, evidence supporting its use in rehabilitation after stroke to improve motor function is mixed. This multi-center trial, conducted in Switzerland, assessed more than 600 participants who had experienced acute ischemic or hemorrhagic stroke with hemiparesis. They were randomly assigned to receive either levodopa-carbidopa or a matched placebo 3 times daily for 39 days, along with standardized rehabilitation therapy. At 3 months, the adjusted mean between group difference in motor function, calculated using the Fugel-Meyer assessment, which was the primary outcome, did not vary significantly by group.
We had a chance to hear from reviewing editor, neurologist, and JAMA Deputy Editor Dr. Chris Muth, who says,
some stroke rehabilitation clinicians are currently using levodopa with the goal of enhancing motor recovery in patients with limb weakness after stroke. The results of this study indicate that this practice is not well supported, and in this sense, this is an important neutral trial that may influence clinical care.
Those insights from Chris really help put these results into perspective. Let's switch gears and talk about health insurance coverage among U.S. children. Professor Shen and colleagues used a microsimulation model, synthesizing national data from 2015 through 2019. Using this approach, the authors estimated that 61% of U.S. children were ever enrolled in Medicaid or the Children's Health Insurance Program, or CHIP, and 42% were ever uninsured by their 18th birthday. Among children born with Medicaid or CHIP coverage, the share ever uninsured was 59% in states that did not expand Medicaid under the Affordable Care Act versus 36% in expansion states.
It's important to be aware of these gaps, especially given recent policy changes. Dr. Vassam and colleagues contributed an editorial for this study. They explained that these models, quote, highlight both the pervasiveness of churn and the urgent need for innovative approaches to preserving insurance coverage during childhood, unquote.
Linda, JAMA published several research letters this week. Dr. Nguyen and colleagues analyzed payments made to healthcare professionals and teaching hospitals by manufacturers of FDA-authorized AI and machine learning-enabled devices. The researchers reported that more than 90% of FDA-listed manufacturers disclosed no such payments from 2017 to 2023. However, more general payments like consulting fees or gifts doubled.
This certainly highlights the need for greater transparency in reporting as these devices gain more widespread use in healthcare. And speaking of gaining widespread use, let's focus on Glucagon-Like peptide-1 receptor agonists, or GLP-1RAs, that can treat diabetes, obesity, and other related conditions. Recent changes to Medicare Part D may change coverage and costs for these medications. Dr. Klebanoff and colleagues used Part D formulary files to evaluate various issues, including prior authorizations and average out-of-pocket costs. They concluded that prior authorizations became near universal and out-of-pocket costs increased substantially over the study's time frame of 2020 to 2025.
There are some interesting viewpoints this week in JAMA. Dr. Coe and Professor Olivet wrote a viewpoint about homelessness policy. They discuss current federal policy and offers suggestions for implementing effective cross-system solutions.
Another JAMA Viewpoint focuses on the increase in medical trainee unions in the United States. Dr. Frederick and colleagues explore the pros and cons of unionization in today's healthcare systems. And in a separate viewpoint, Dr. Schwartzstein and Alexander Iyer discuss how teaching critical thinking skills, in addition to pattern recognition and illness scripts, can be an irreplaceable asset for learners.
And in her viewpoint, Dr. Solenkova writes about the challenges recent limits on J-1 visas have created for international medical graduates and the potential implications for the domestic physician workforce.
This week's JAMA Insights article is by Dr. Zygmunt Fischer and colleagues. They offer evidence-based strategies for clinicians communicating medical numbers with their patients. Author Dr. Fagerlund talks with JAMA senior editor Dr. Ann Coppola to discuss how this can help improve shared decision-making with patients.
Your first recommendation is numbers, even approximate, should be used to describe risk probabilities. Can you explain what you mean by that?
Yes, a lot of times what we see happen is that clinicians are using words to explain the risks or benefits of something. That's a low risk. That's a common risk. That's a high risk. And what happens in that case is people don't really understand what that means or what their definition of a common risk is, or a high risk could be very different than what the clinician actually means. And that can cause a lot of problems. So for example, when a clinician might say, oh, that's a high risk of something happening, what they might be meaning is like, oh, a 1 or 2% chance of a side effect or a 4 or 5% chance. But a patient might be thinking, oh, a high risk, that could be like a 25 or 30% chance of a risk. I am not going to take that kind of risk. And so I'm not going to do that procedure, or I'm not going to take that medication. And so what we're recommending is that clinicians really try to use actual numbers, because patients may be defining a common risk or a high risk very differently than the clinician.
And JAMA has a highly relevant patient page about lower urinary tract symptoms in men. About 40% of men over age 50 have lower urinary tract symptoms, so many patients may benefit from this information.
And before we wrap up, keep in mind the latest articles in clinical medicine, biomedical research, public health, and health policy written and researched by our outstanding JAMA Medical News team at jamamedicalnews.com, or you can click on the link in the show notes.
Thanks, Preeti, and thank you for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Shelley Steffens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in the episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.